All right. Any questions from anything we covered before? Hope my voice will carry and people say, "Oh no, I must get back to class." In the interest of time, I'm going to go straight through to lunch. That way, I'm not cutting into your lunch period. Okay? Is that reasonable? Please don't let that reflect negatively on my reviews, if you don't mind. Probably be more negative if I did cut into your lunch. So. Anyway, so we're talking about surgery meds today, and again, there are not a ton of meds that are really specific to the act of surgery. However, there are a lot of meds used for surgery, right? So here's we're going to talk a lot about anesthetics, analgesics. We'll talk about other sedatives, things like that. And of course, I have a strong love for this stuff. My dad's actually a nurse anesthetist. He had a T-shirt we got him one year that was the Ether Bunny, if anyone's familiar with The Far Side. And again, if I'm nothing if not my own father, so this is where a lot of my humor comes from. Anywho, so some of the things we're going to focus on when you're performing surgery, again, this is kind of a large spectrum, right? So it can range anywhere from doing procedural sedation, say like in the ER, someone has a fracture that needs to be reduced or a laceration that needs to be repaired, all the way up to like general anesthesia needed for like say full-on surgery, right? And so we're going to talk about this balanced anesthesia that's looking to use the right kind of mixture of drugs, the right doses, the right concentrations and everything to get the right level of sedation, right? And so in some cases, you don't need a patient to be full on under general anesthesia for something relatively minor, right? Because again, that requires a lot more monitoring, there's a lot more side effects, requires things like mechanical ventilation, etc. You don't want to necessarily have to do all of that. So some of the other things we'll look at, when we say inhalational anesthesia, that just means it's going to be medications that you inhale in order to generate the anesthesia, pretty straightforward. Another term we'll use is minimum alveolar anesthetic concentration, or MAC. What do you think that means? Well, it's minimum alveolar anesthetic concentration, right? That's the acronym. What do you think that means? It's kind of like LD50 or ED50 way back in pharmacodynamics, right? Basically, it means the amount of drug it takes to get 50% of people to be a responder, right? So again, in the case of anesthesia, what do you think would be our response? Are they awake? Or are they asleep? Right? It's kind of a yes/no sort of thing there. And so in this case, when you're performing surgery, do you think you want to use drugs at the MAC? So you're going to surgery, there's only a 50% chance that you're actually going to go to sleep. No, right? You're going to use doses much well above that, but what's the point of that number? Why is that helpful? It's a good comparison point between different drugs. We can compare the max between different drugs to determine which one's more or less potent, right? And so that's just a helpful number, but you'll see that come up throughout this lecture here. Analgesia just means what? Pain relief, decreased sensation of pain, right? When I say general anesthesia, what do you think that means? It's above like lieutenant anesthesia, right? Basically means you have a general state of unconsciousness, right? The patient's not responding to verbal or painful stimuli. The muscles are very relaxed. You have this loss of reflexes. Again, what do you think the respiratory drive is like at this point? Pretty minimal, right? So that means we're probably going to need to take over and actually breathe for that patient, right? So you're going to find a lot of these medications are going to take a hit on the respiratory drive, which is an important aspect of monitoring, as we're going to see in a little bit. And so again, when we say anesthesia, it really just means a state of that is induced by these general anesthetics, right? So we'll talk about local anesthetics and then general anesthetics and how they kind of differ between the two. But when we say anesthesia, we're really usually referring to the act of using these more general anesthetics here, okay? Again, so we're going to look at the depth of sedation. We're going to look at the different aspects of these drugs to see just how far along that spectrum you can go, right? And my dad always described it. I remember asking him, like, what do you do for a living, Dad? I don't know how we got to that stilted sort of conversation, but I asked him, basically, what do you do? And he's like, well, basically, I get people as close to death as possible for surgery and then bring them right back out of it. I was like, that sounds really cool. I kind of interested in that, and so this is why I kind of like these drugs so much. Because again, they say anesthesia is like a whole lot of boring right in the middle. You have a lot of activity at the beginning and a whole lot of activity at the end, and hopefully your patient comes out alive. So, hopefully. Anyway, when I say amnesia, what is amnesia? Loss of memory, right? So you're not retaining new memories at this point. We'll talk about things like anterograde versus retrograde amnesia. What's the difference between those two? Yeah, so retrograde would be you're forgetting stuff behind a certain point in time, before a certain point in time, or anterograde means you cannot make new memories from a certain point in time. This is usually that point in time is going to be when we're giving drugs, right? So if I give you a dose of, say, a benzodiazepine, I give you a big dose of Versed there in the ER, you're probably not going to remember a whole lot of what happens for the next hour or so, right? which is good because we don't necessarily need them to be aware of what's going on. We don't necessarily want them to remember having that laceration being sutured and things like that. That's okay if they don't remember all of that. So we'll talk about that a little bit. A lot of the drugs we're talking about here are going to be forming more of that anterograde sort of amnesia. So that's the main thing we're focusing on there. Again, this is going to cause other things like skeletal muscle relaxation. Why do you think that's important for surgery?
You want them flailing during surgery.
Well, yeah, so you don't want them flailing around, so that's a good thing, right? And that's where things like neuromuscular blockers are going to be useful, for helping them to cause paralysis. But think about if you're performing, say, like an orthopedic procedure, right? You don't want those muscles tensed up. You want things to be loose, so that way you can do whatever manipulations you need to do. Usually when people are in pain, I think about this from an ER perspective. If someone dislocates a shoulder or if they have a femur fracture or something like that, those muscles are very tensed up because they're in a lot of pain, right? And in order to reduce that, like, you need them to be loosened up, and that's what a lot of these drugs will also do. Provide analgesia, the amnestic properties. They will also provide muscle relaxation, which is good. Okay. And so these are all things we're going to be looking for. And again, as far as sedation goes, we should expect decreased levels of activity, alertness, arousal. And again, it's a big spectrum, right? So again, you could be sedated and still be somewhat responsive to verbal stimuli, or you could be to the point where you can do sternal rubs and they're just not responding at all, right? So again, it's all along the spectrum. And we'll talk about things like light versus moderate versus deep sedation, but just know there's a lot of areas of gray between those. It's not like a patient just automatically flips from one to the other. Okay, just be aware of that. And again, typically the more further down you get on the sedation sort of rabbit hole, so to speak, you're going to be seeing less or more effects on like cardiovascular stability. You're going to be seeing less respiratory drive, etc. Okay. Anyway, again, we kind of covered these definitions here. Amnesia is just really focusing on the actual memories of things that are happening there. So again, do I remember getting my fracture reduced? Versus the analgesia is helping just with the pain aspects. And so individual drugs will not necessarily provide one or the other. They may provide both in some cases, just depends. So for instance, like an opioid, like fentanyl, is going to more provide what? More analgesia than it is amnesia. How about like a benzodiazepine? More amnesia. Does benzo provide any analgesia? Not in the strict sense, right? Not like we're thinking with something like a fentanyl. Now, if it's caused by muscle spasm and you relax that muscle spasm, then yeah, you could consider that effective there. But for our purposes, no, right? You're going to see there's a big delineation between those two. And so they're very synergistic when you're working with these drugs together, right? So this is why we use a combination of drugs to get more effect than just either one by themselves. And so we're focusing on this kind of balanced anesthesia. And ideally, what do you think like an ideal anesthetic? What kind of properties would it have? So the onset, you think, would be kind of slow or fast? Fast onset, right, because you want to perform your procedure right now. Okay. How about the offset? How fast do you want them to recover? Pretty fast too, right? So you want to have fast onset, fast offset. So when you're done with the procedure, they will wake up and they can start to recover. You'd like to have a wide safety margin, right? So even if I change the dose slightly, I shouldn't really see big differences in safety profiles. So this is all ideal. Do you think we have any one perfect agent? No, right? So every agent is going to be good in a specific situation, and we'll kind of talk about that and which drugs are better for which sort of clinical situations there. So looking at our choice of anesthetics, as I mentioned, it depends on the type of procedure you're doing. Are you just doing like a dental procedure that is just requiring sort of local oral sort of anesthesia that you can just use things like minor sedatives and maybe some local anesthetics like lidocaine? That could be one situation, right? Versus more major procedures, you're going to be getting preoperative benzodiazepines to help with, what do you call it when you're decreasing anxiety in a patient? Anxiolysis, right? The drug is an anxiolytic, but you're inducing anxiolysis, right? So you're helping with the preoperative anxiolysis. You're helping with start that amnestic sort of properties there. They're going to get intravenous anesthetics. This is what we call induction. When I say induction, what do you think that means? You're putting them out, right? You're knocking them down very quickly there. I always think about that movie Inception, right? When they start that IV immediately, everyone's like, it'd be awesome if we had drugs like that, and I really wish we did, but unfortunately our drugs do not work that well. And so you start off with an induction sort of agent, and then you focus on the maintenance of anesthesia. And this is where a lot of our inhalational drugs are going to come into play here. Okay, but again, you have to use a combination of drugs in order to get the desired state. And so the general types we're going to run into are going to be our inhalational drugs and then our intravenous or parenteral sort of agents there. Now, inhaled anesthetics, these are things that you'll be basically breathing in, usually via endotracheal tube. Once you'll have the patient undergo induction They are very well sedated. You get them intubated, and then you can start to administer these volatile liquids. They will then breathe in. You don't have to be intubated. There's some other cases we'll look at, things like nitrous oxide, but that does not need to be the case there. And the most common ones I run into are going to be things like isoflurane, desflurane, and enflurane. We'll go into details on these in just a minute. And then we also have nitrous oxide. This is going to be really good for more like procedural sort of sedations, more light sort of procedures, and I'll talk about that in just a second. From the intravenous side, we have a lot of different agents that are here. We have things like our barbiturates. Anyone remember a barbiturate we've talked about before? Phenobarb is a common one you think about being used for what? For seizures. Yeah, we have other ones we can use for sedation, like pentobarbital, sodium thiopental. We'll talk about those. Benzodiazepines. We'll have propofol. And we know what celebrity made propofol famous? Michael Jackson, right? We'll talk about that a little bit. We'll talk about ketamine. And we know a certain name for ketamine. Special. Wow, some of you guys knew that real quick. Very interesting. Very interesting. We'll talk about our opioid analgesics, and then some kind of mixed sort of sedative hypnotic agents. And then again, we're either using these by themselves or in combination together, because again, they will have some synergism there, not only for the therapeutic effects, but also from a side effect profile, right? So again, if I use a benzo by itself, pretty safe. If I start to mix that with an opioid, you're going to run bigger risk of having cardiovascular instability, more likely to see respiratory depression, etc. Okay. So, and again, the idea is to have a balanced sort of action here between your different medications. And so we're going to see that the inhalational drugs are good for maintenance of anesthesia. They're not really good for, as induction agents. The intravenous agents are going to be good from an induction standpoint because you're applying them intravenously, so they get in the system very quick. They have their onset very quickly. And then we'll also find there's some routes for using local anesthetics for causing local blocks, essentially, right? So, and again, do you remember how we talked about that our local anesthetics worked? Sodium channel blockade, right? They prevent those propagation of those painful signals up into the CNS. And so by using local blocks, you can try to prevent those signals from moving up. What's the benefit of using something like that? Yeah, less systemic side effects for sure. What else? Ultimately, what class of drugs are we looking to not use as much of? Opioids, right? So these will have to limit the amount of opioids we're having to administer. Also think about things like spinal blocks or epidural blocks. They allow us to provide very small amounts of drug relative to what we would need to provide systemically to get the same sort of effects. So I think about like labor, pain, using an epidural for those patients. Again, relatively small amounts of drug applied directly into the epidural space to provide analgesia for just a portion of the body as opposed to providing systemic sort of effects there, right? Anyway, so there's several stages of anesthesia here. We have one, the state of analgesia. They'll then move into the stage of excitement. Now, does that sound conducive to performing a procedure? Nope, it's not going to be good. You'll have the stage of surgical anesthesia. This is generally where you're going to be shooting for more significant procedures. And then you'll have the stage of medullary depression. Does that sound good? No, this is the one you want to keep them out of, right? So again, when I mentioned my dad saying take them as close to death as possible, you want to stay away from that stage there, right? If you remember that movie Inception, it's like getting down to limbo. You don't want to go there, right? It's a very good movie. You should check it out if you have not. In your free time, which you have a lot of, I'm sure. Anyway, so the stage of analgesia, this is the initial stage they're going to be hitting here, and you'll find that typically will have pain relief, but they won't really have a whole lot of amnesia associated with this stage here. So imagine getting, a dose of fentanyl after you break your arm or something like that. This will provide that state of analgesia. It's not going to be amnestic. You're not going to see a large amount of sedation here. Again, it all goes to the dose that you're going to be administering. But typically, this is going to be just our first stop as we move on deeper down to these deeper levels of sedation. The stage of excitement is the one we're trying to get away from. We don't want to spend too much time here because you're going to see that the patient is going to be a little volatile, not really all that cooperative to what we're doing here. You may find the patient appears sort of delirious, maybe still vocal, right? The patient's amnestic, right? They're not going to remember what's happening here, but they may still have some vocalizations of what's going on, or they're saying like, hey, there's spiders walking on the wall or something like that, and there's nothing there. Like that's things you could see at this stage. Typically, respiration rates are going to become irregular, so the rate and the depth is going to become irregular and may not be ventilating appropriately. Vomiting is a big one as well, you're going to see here, because again, we're kind of disrupting the CNS. We know that the chemoreceptor trigger zone is there. It can be overactive. That can cause vomiting. And what could be a problem for a patient vomiting when they're in this sort of sedated sort of state? Aspiration, right? And that's one of the big things we're trying to prevent in this case here, right? Aspiration leads to what? Chemical pneumonitis, right? Because again, you're having this irritant that's getting in there. Now, again, they could have risk for things like, anaerobic pneumonias, things like that. But typically, it's just that bile acid, or all the stomach acid and things like that, it typically is pretty irritated to the tissue there. So you see more of a chemical pneumonitis. And so again, typically we're giving drugs at doses such that you're trying to limit as much time in this state as possible, so that we get to more of the deeper states that stage 3 is talking about. As they exit from this, you're going to see they get to a more regular rate of breathing, maybe a little bit more shallow than would be at baseline, but it should become more irregular at that point. In stage 3 is going to have that, again, that recurrence of regular respiration, and then it's going to extend all the way down to pure apnea, right? And again, this is typically where we're providing that ventilatory support for these patients. And you're going to see that stage 3 is then broken down into 4 further stages. And I have some pictures that will kind of give you some examples of what this looks like as far as, different, physical exam findings you're going to see with that. And then finally, stage 4 is that medullary depression. This is the deepest stage. This is basically, we're going to find the vasomotor center of the medulla is going to be inhibited here. You're going to find a lot of cardiovascular instability. You're going to find the respiratory center is going to be completely shut down. So again, you're providing all the respiratory support for them. And again, death can rapidly ensue if you're not providing support from that. Right, so oftentimes you're going to find, especially when you need really deep levels of sedation, that we are providing extra help for things like cardiovascular stability in addition to providing the ventilatory support. So typically you'll find the anesthesiologist or the CRNA or whoever's operating that part of the bed is going to be one doing a lot of monitoring to see what's going on, but you can also find that they'll be helping to regulate things like blood pressure. They'll have basically, especially like in cardiac cases, they'll have 2 syringes. One will have nitroglycerin in it and one will have phenylephrine in it. I mentioned nitroglycerin before. What does that do? Cause vasodilation, right? So they get hypertensive, give them a little squirt of nitroglycerin, blood pressure goes down, right? What does the phenylephrine do? Vasoconstrict, right? Well, how does it do that? Alpha 1 agonism, right? It causes vasoconstriction. So you see they'll be kind of riding this line between, keeping the blood pressure right in the range they're shooting for, in addition to watching the respiratory sort of the aspects of the patient. Anyway, looking at this this picture here, I think kind of gives you a good idea of what we're looking at. So again, just normal doses of analgesics. We're providing patients morphine, fentanyl, etc. We'll keep them here in this realm. And again, these patients are still going to be responsive to you. Shouldn't have a whole lot of amnesia yet, unless you're starting to get a little bit kind of deeper here. The stage of excitement, where this is not where we want to be. We're going to kind of blow past this, and that's why we use a lot of our induction agents, like IV, propofol, or ketamine, or something like that, to kind of knock them down. And then this is where we want to be. Typically stage 2 or 3 is going to be generally pretty good for our patients to keep them where they are sedate enough to where they're not going to be responding to the things we're doing to the patient. We can do whatever procedures we need to do without having to worry about this kind of really unstable sort of patient from a CV sort of standpoint down here in stage 4. Kind of make sense? Anyway. Again, just another table kind of showing you what you should be looking for as far as the different stages, what's going to be happening here at these different aspects. Okay, so with the inhaled anesthetics, as I mentioned, they're going to be providing more of that kind of maintenance sort of sedation. So we'll knock them down the IV agents. We'll provide maintenance sedation with the inhaled agents here. And so some of the things that go into how well these drugs are going to work. So how could I change the dose of an inhaled anesthetic, do you think? Yeah, so you have to think about the flow of the drug, right? Because you're increasing basically the concentration of the drug that you're administering to that patient, right? So again, by the inspired air that's coming into the lungs, by increasing the concentration of that anesthetic, you're going to get a bigger dose, essentially, right? So that's one thing you have to consider is what percentage of that. Now again, can I turn that all the way up to 100%, just pure anesthetic they're inhaling? No, why not? If it's 100% anesthetic, there's 0% oxygen, right? Yeah, so again, it's the balance between those two, right? So you want to make sure you're providing enough oxygen to the patient. And so again, more potent agents allow for smaller percentages of gas that we have to administer in order to keep the patient sedate. So just some things to consider there. But that's that partial pressure, that tension that we're providing to get into the lungs itself, okay? Now, once it gets into the lung, into the alveoli, how does it get into the brain? Well, it's a partition across the alveoli to get into the bloodstream. And then from there, where does it have to go to? Right, it has to cross the blood-brain barrier, right? So what kind of drugs would be very more suited to do that? Lipophilic drugs, right? So again, looking at the ability for these drugs in terms of lipophilicity to cross these membranes to get into the bloodstream and then to get into the blood-brain barrier will determine how quickly they're going to be working, how much you need potentially, right? Because you may need to provide higher concentrations in order to drive that concentration gradient to force the things across so they don't cross that easily on their own. But also think about the offset as well. What do you think is going to be a faster offset? Something that's more lipophilic or hydrophilic? Because if it crosses easy into the CNS, it'll cross easy out of the CNS. So that also helps with the offset, right? So again, if I have something that's very lipophilic, I don't have to provide a whole lot of it into the inspired air. They'll then cross over these membranes very easily, and then they'll come back out once I stop giving it to them, and that can help with what? With recovery, right? Them waking up and getting back to baseline so that I can get them out of the PACU. Anyone know what PACU stands for? Post-anesthesia care unit, right? So again, they go from the OR, they go into the PACU, they're waking up, they're getting their analgesics, and then you're sending them on the way back to the floor or to discharge, wherever the heck they're going to go to, right? So again, that's the whole goal, is we want things to have fast onset and fast offset. Not every drug is going to fall into that category, but that's some of the things that will influence how well it does that, okay? And so again, you have to have this transfer occurring here. You can either overcome that by giving a bigger concentration of the drug or by having something that's more lipophilic. And I'll show you how that kind of plays into some of the characteristics of these inhaled anesthetics. So as I mentioned, these are the properties here, the solubility properties, the concentration in the inspired air. The volume of pulmonary ventilation plays a role too, right? So what would help to enhance the analgesic effects or the anesthetic effects of these drugs? Larger or smaller volumes? Larger volumes, right? You're going to get more lung being filled up with that anesthetic, thus you're going to have more partition occurring there. Yeah, so that's going to work there. Pulmonary blood flow. If this is impeded, what do you think it's going to do to the onset of these drugs? It's going to slow it down, right? So again, if they have any issues like pulmonary hypertension, you may find you have to provide more drug in order to get that drug across because you're decreasing that pulmonary ventilation that's actually occurring there, right? Pulmonary blood flow. And then again, looking at the partial pressure gradient between the arterial and the mixed venous blood side can also play a role here as well. Again, by increasing that concentration, you're going to get more effect happening. So, and again, just to give you an idea of the different anesthetic solubilities here, we're going to find that on this y-axis here, we're going to find the arterial anesthetic tension, right? So again, it's basically the concentration on the arterial side and versus time. And you're going to find that basically this is a percent of the inspired tension. So basically what percent is crossing over from the inspired air over into the actual arterial side of things, right? And you're going to find that by increasing that solubility, this is going to go up much more quickly. You're going to find that onset's going to be a lot faster, right? So things like nitrous oxide kick in pretty quickly versus something like halothane or methoxyfluorine are going to be a little bit slower. Okay, so again, you're going to have to like rote memorize these kind of slides here and tell me specifically when the plateau effect occurs. No, but I want you to at least have an idea of like why some things have a faster onset than others. Know those principles that go into that, like the physiochemical properties of the drug heavily influence how well these work. So how do these anesthetics work? Well, we think they work through GABA. We don't have a full idea of how they specifically work, but GABA is a pretty good place to start. Normally when GABA A channels are activated, what occurs? You open up those channels, what flows in? Chloride, right? Remember, just like with the benzodiazepines, just like with the barbiturates, by allowing chloride to flow into those GABAergic neurons, chloride flows in, what happens to the negativity of that cell? Yeah, it gets more negative. You hyperpolarize the cell, which makes it what? Yeah, it's going to be much more difficult to trigger an action potential. So by doing that, you're slowing everything down, right? Which makes sense why you'd end up having the state where you start off with analgesia, as you keep increasing the dose, eventually you're going to shut everything down by hyperpolarizing all these neurons, and that's when the patient maybe dies, right? So, but if you think about it, like, why do you think they get that stage of excitation? We kind of talked about it briefly before when we talked about paradoxical reactions that maybe like kids get to things like Benadryl or to benzodiazepines. Why do you think that occurs? Does your body think it's dead? No, because again, stage 2 is pretty early on, right? It's right after that stage of analgesia. So again, we're trying to blow past that if we can. But if you think about it, like remember, and again, I know you guys don't do this, but if you were to ever consume alcohol, right? Remember that when you have like a drink or two, what kind of happens? What kind of physiologic effects do you experience? Are you like immediately like passed out on the couch? Hopefully not, right? Hopefully no one has that low of a tolerance. I guess it depends on the drink, right? If it's like pure rubbing alcohol, maybe. But let's assume it's just normal sort of commercial alcoholic beverages. After a drink or two, you notice like you have that loss of inhibitions, you get a little bit more that social lubricant sort of effect there. You're starting to inhibit some of those inhibitory neurons essentially, right? So you're taking the brakes off the system a little bit, and so you can see a little bit of excitation. Well, similar things can happen with these sedatives like benzodiazepines, like these like diphenhydramine, right? So again, you'd expect them to be sedate, but they end up getting excited. So that's how I kind of think about it. But by giving a big enough dose, you're going to bypass that because you're going to start to have more of a global inhibition of all these different neurons by activating those GABA A channels, right? Too much chloride flowing in, cells are hyperpolarized, you're just not going to have an action potential, okay? So that's how we think they're working there. And again, you're going to find that by mixing these drugs together, you can see how they're going to be very synergistic. Because if you remember, how do benzodiazepines work? Remember, they facilitate GABA working better, right? They bind onto that benzodiazepine site, and they allow for GABA to bind more readily to the receptor to allow it to open up more readily, right? So you can see how there's a lot of synergism here. We're going to find that by mixing these agents, you're going to get a lot more sedation than either one of them would by themselves, okay? So you can keep that in mind because this is where a lot of the side effects end up coming from, right? Okay, so again, typically you're going to find that these are combined with IV agents, not all the time. Specifically, like nitrous oxide, you'll see occasionally used by itself for more light procedural sort of sedation here. But nitrous oxide, halothane, enflurane, the three big ones that I'm going to focus on, actually I guess the four big ones I'm going to focus on are nitrous oxide, and then the three general anesthetics I'll focus on are going to be isoflurane, sevoflurane, and desflurane. These are the ones I see used most commonly in the operating suite. Nitrous oxide are going to be used much more commonly for more like light procedural sedation sort of things. When I say procedural sedation, what does that mean? It's like a quick procedure, right? So I'm suturing up a laceration, I'm reducing a fracture, something I don't need like a general anesthesia for that patient, okay? We do it a lot for, say, like, for instance, lumbar punctures prior to getting intrathecal chemotherapy. We do procedural sedation for those patients. I'm trying to think of other big procedures we do that with most commonly. Those are the big ones, right? Or if like patients are getting like, Botox injected in certain muscle groups, sometimes we'll do procedural sedation for those patients. Anything where you don't need them to be fully sedated, where they need to be intubated, but they're still able to breathe on their own, that's more light sort of procedural sedation. That's kind of what I'm talking about. Okay, I'll highlight some clinical examples as we go forward. So anyway, looking at minimum alveolar anesthetic concentration, that just allows us to compare the difference between these different anesthetics to determine which ones are more potent. Obviously, a lower number means it's more or less potent. It's more potent because I need less drug in order to get those patients to fall asleep, right? Because again, that's that 50% mark, when 50% of those patients are going to be considered to be sedated there. And again, this is when they're not responding to noxious stimuli, right? So examples of noxious stimuli include what? Sternal rubs, purple nurples, whatever you got, right? Whatever kind of painful stimuli you got there, right? My lectures could be considered a noxious stimuli. Sometimes we'll play those for patients who are a little sedate, try to wake them up a little bit, lots of different things. It's kind of ironic because you can also use my lectures for insomnia as well, so it kind of works either way, right? So again, looking at this, you can find that different physiologic conditions will actually dictate how well some of these drugs are going to work. So some things can change what that minimum alveolar concentration is going to be. So for instance, a decreased MAC, meaning the drugs are working better, include things like more elderly patients, they're hypothermic, these drugs tend to work better, so that will then mean you need less drug in order to get the same effect. Typically, you're going to find that the sex of the patient, height, the weight of the patient really has no big effect on this. So again, the concentrations of drug you may be administering could be the same whether it's a man, woman, could be if you're dealing with a basketball player versus a very short person, could be if you're dealing with anyone of any weight. You're going to find that does not really affect the amount of drug you have to administer. However, other things could be affecting this. It could increase the MAC, meaning you need more drug. Include things like pregnancy. These women tend to have a little bit more resistance to some of these agents here. Things like alcohol abuse. Why do you think alcohol abuse would be making them more resistant to these drugs? Has to do with GABA. What does alcohol do? How does it cause sedation? It actually enhances GABA as well, right? Again, I mentioned alcohol almost works identically to the benzodiazepines, right? Essentially, they're making GABA work better, or having to activate those GABA channels. So by doing that, you can see that someone who's chronically abusing alcohol, what happens to the GABA channels when they're constantly being activated? They upregulate, they downregulate. They start to downregulate because you're constantly hammering on them with the alcohols. That means you're going to have less GABA effect when you have other drugs come along. They become much more tolerant to those effects, right? So that means you need more anesthetic in order to have an alcoholic patient to knock them down because they're much more resistant to those effects because their GABA channels are going to all be downregulated essentially, right? Because if you remember when we talked about benzodiazepines, when you withdraw someone from those drugs, what's the response they have? Seizures, right? They can result in seizures. They get very hyperexcitable because they've had that downregulation of all that GABA, so you have less GABA effect, and consequently you have more what effect? What's the opposite of GABA? glutamate, right? And glutamate we know is very excitatory. So this makes sense why someone who has a history of alcohol abuse would be more resistant to the drugs. You need more in order to get the same level of sedation there, right? And again, that goes along the chronic use of centrally acting drugs. That basically means like things like benzodiazepines, muscle relaxants, anything that's going to be primarily sedating, you're going to be more resistant to this. So kind of think about the patient case, think about kind of what their comorbid conditions are and how that might affect how well their drugs are going to work. So again, you can imagine here, this is kind of looking at the MAC fraction here. You're going to notice that typically when we just need like amnesia, we can use lower doses here in order to get these effects that we're looking for, versus as you start to increase that dose, you're going to get well above that MAC where you get all the way to the, they're completely sedate, they're not responding to any kind of painful stimuli, completely immobile, muscles all relaxed, right where you need them to be for general anesthesia. So other effects we can see, so again, we know these general anesthetics are going to have effects on other aspects of the body as well. We're going to find a lot of cardiovascular effects. In some cases, you're going to find hypertension. In some cases, you're going to find hypotension. In some cases, you're going to find bradyarrhythmias, sometimes tachyarrhythmias. So again, it gets a little complicated depending on the patient. But generally, from a respiratory sort of standpoint, you're generally going to find respiratory depression is the most common thing. Especially the deeper level sedation you get, the more respiratory depressed they're going to be, and the more we're going to have to provide that support for those patients, right? They may still have some voluntary respiratory drive, but oftentimes we're going to be taking over for them by providing that via the endotracheal tube, via the ventilator, right? Typically from a cerebrovascular standpoint, they'll have a decreased metabolic rate, which could be good if they had maybe something like a recent infarct or something where they're worried about, that tissue dying off. And they're also going to find that as far as renal and hepatic blood flow goes, typically is going to be decreased, which means you're going to have less drug being delivered to the tissue. Maybe you're going to have less elimination happening there, so it could affect metabolism with some of these other medications the patient may be receiving. So getting into some of the drugs we used to use a little bit more commonly, again, just for historical perspective, we have things like halothane, a very potent drug. And again, we know it's working those GABA-A receptors, try to open up that channel to allow more chloride to flow in. And so it had medium rate of onset, medium rate of recovery. It's not really ideal from that sort of standpoint here. And also you find that it would really lack any sort of analgesic potency, right? So although it caused sedation, it didn't really deal with any analgesia. So you'd have to give something else in order to achieve that, right? So things like, opioids, things like, barbiturates potentially, muscle relaxants, etc. Again, how do you think most of these drugs are going to be eliminated? They're just going to breathe them right out in most cases. You find some of them will undergo some hepatic elimination, but for the most part, they're just going to be expired right back out in the breathed air. Another one you're going to see as well as enflurane, though this one was less potent than halothane, it had a little bit better onset and recovery than halothane did, so we kind of like this a little bit. But one of the big things you found as well is that because these agents are hydrocarbons, essentially their chemical structure, they tended to irritate the heart a little bit. Right, so just like you ever hear someone who's like huffing Freon, like off a AC unit, or if they're huffing like paint thinner or something like that, these are similar sort of chemicals that they're inhaling, and they all irritate the heart, right? So they can actually end up developing dysrhythmias. And again, when your patient's undergoing anesthesia for a procedure, do you want them to develop a dysrhythmia right in the middle of surgery? No, not typically. So you're going to find that these agents kind of didn't have that, weren't ideal from that standpoint. We kind of moved away from them a little bit, right? So this is why you can see things like EEG changes. You can see some seizure activity. So hypotension, have a little bit arrhythmias. This and halothane both had arrhythmias associated with them. So they weren't ideal. We kind of moved away from these for the most part. So now we have a few other agents like isoflurane, desflurane, and the sevoflurane. These are the three most common ones that I see at least being used, at least at our hospital. Use these exclusively. Isoflurane was nice because it had better muscle relaxant effects, which makes the patient more pliable when you need to do your procedures, whatever the surgery may be. And he found that had better rapid induction and had a faster onset than some of the older agents did. And he found that the awakening was a little bit faster as well. And again, this is good because you want patients to wake up faster so they can recover and go to wherever they're ultimately going to go to after surgery. And you found there's a lot of little post-anesthetic organ toxicity or seizures. So again, limited side effects, better pharmacokinetic profile, which made isoflurane very popular for a while there. Also lack of arrhythmias, etc. Side effects, though, you'd expect respiratory depression. We understand that's going to happen. That's an anticipated side effect. That's again why we're providing ventilatory support for the patient. You may see things that increase cardiac output. Now, who might that be a problem for? Maybe CHF patients. Yeah, who else? Patients may be prone to myocardial ischemia because cardiac output goes up. What else goes up in the heart? oxygen demand, right? So again, if they're at risk for MI, perhaps this could induce that by increasing cardiac output, something to think about. Hypotension as well, right? So again, you're typically will see that if it's inducing that hypotension, cardiac output's going to go up to try to respond to that, right? We had desflurane or Suprain. Again, we see this used a lot for things like emergency situations. We see this used for outpatient surgeries potentially. And again, not a very good induction agent. So this is where you'd really need something else on top of it, like a propofol, a ketamine, a thiopental, or something else to really knock the patient down. And then you'd have this for more maintenance of anesthesia. The nice thing though is that it recovers very rapidly. So only about 5 minutes or so, and the patient should be recovering, back, get the respiratory drive back, start to wake up a little bit, and that's very beneficial from that standpoint. However, you can see things like myocardial depression. So you can see decreases in cardiac output there. You can see things like coronary and cerebral artery dilation, which may or may not be a problem for certain patients. And then laryngospasm. What is that? Basically, the vocal cords are going to spasm up, and what does that impede? Airflow, right? Which is typically not good if the patient's not intubated. So that can be a problem because, again, your patient's starting to recover, you extubate them, and again, anytime you're irritating the vocal cords like that by having an intratracheal tube going through them, that can also increase your risk for laryngospasm as well. So all of a sudden they start to spasm up. Notice they're not oxygenating very well. How do you think we treat that? Basically, got to resedate them, and also we end up giving them something like a paralytic. Paralytic agent is going to allow that to relax and then allow you to intubate. We'll talk about intubations much more when we get into the emergency medicine section. That'll be in the last quarter of the course, and we'll talk much more about neuromuscular blockers and paralytics and all that good stuff, right? So, but anyway, so you can see that there are some side effects we know with this, and oftentimes we'll have medications available just in case they develop this. So, for instance, we have a laryngospasm kit that is available in the PACU on the off chance that a patient does develop this laryngospasm, just like we would have, say, for instance, a anaphylaxis kit available in the infusion center when we're giving infliximab, right? You have to have these medications available in case these emergencies do develop. Because again, you don't want to be caught with your pants down, so to speak, and not have any medications available if they do have one of these really negative outcomes. So, and then we had sevoflurane or Ultrain. Again, very rapid onset and recovery, so ideal from that sort of standpoint. See this used in a lot of outpatient settings, certainly in the OR as well. And again, see things like bradyarrhythmias, tachyarrhythmias. Again, it could be either in some cases. Hypotension is going to happen here, so just be aware. A lot of these agents are also going to have a lot of nausea, vomiting occurring after, especially when they're recovering. So what do you think we can give to deal with that? Zofran is going to be far and away the most common thing, right? So most patients will end up having just a prophylaxis dose of Zofran being given in surgery anyway, just so that way, because it's so common they're going to have nausea, vomiting, they're going to be sedated to the point where they're not protecting their airway very well. You just go ahead and give it to them anyway, right? What are some other drugs we can give potentially? Regalin's another common one. We have this one anesthesiologist, that's all he orders for whatever reason. That's just what he likes to use, it's what he's been comfortable with. Zofran, Reglan, any of them are going to work very well anyway. Again, we talked about side effects of Reglan, but again, this is just like a one-time kind of dose, right? So you're not going to expect to see a lot of problems with that from that standpoint. Okay. And next we have nitrous oxide or laughing gas. Has anyone ever seen the movie Black Sheep? I know it's outdating you guys by a little bit, but it's Chris Farley and David Spade back in the day, and they steal this cop car that has nitrous in it, and they have a leak in the car. You should Google if you can find the video. It's very funny. Gives you an idea what nitrous oxide is kind of like. But basically, this is a really good, very kind of light sort of anesthetic, good for like dental procedures. If you have to do a light procedural sedation, like a laceration repair, and the patient's kind of nervous, you want to kind of anesthetize them a little bit. Nitrous oxide is pretty good from that standpoint there. Now, keep in mind, this is not the same as nitric oxide. That is a completely different drug that we oftentimes will use for things like pulmonary hypertension. This is nitrous oxide, okay? So just be aware, this is N2O. It's also prominently featured in the Fast and the Furious movies. No one's familiar with that? Anyway, so looking at this, you're going to find this is very good for this kind of outpatient procedures, a good supplement to other sorts of anesthetics, okay? Now again, it's incomplete anesthetic, it's not going to work perfectly by itself. No one's going to go under for surgery with nitrous oxide. Not good as a single agent. And again, the excretion is going to be primarily expelled through the inspired air here. Now again, I will tell you kind of I don't know if you guys will find this funny or not, but I remember when I was a young lad, many moons ago, I was getting a dental procedure done as a child. I have a very tumultuous oral history, specifically with my teeth. But anyway, I was getting some teeth extracted due to no fault of my own, and they decided they were going to help me become a little anesthetized by giving me nitrous oxide. Now, of course, at the time I had no idea what I was receiving, but in hindsight, I know what it was. So they were giving me nitrous oxide, I had the dentist come in who's going to do the procedure there, and he said, "Oh, I want to see if the drug is working or not yet." And so he says, "All right, let me tell you a story, and I'll see if the drug is working or not." So he said, "Okay, Panda walks into a bar. Panda orders some food. The waiter brings it out. Panda eats his meal. It's a lovely meal. Waiter comes out to give him the check. Panda pulls out a gun, shoots him, and then walks out of the bar." So the guy at the bar was like, "What the heck's going on? Why'd the panda do that?" And the bartender says, "Well, look up the dictionary definition of a panda." Look it up, and sure enough, it says panda eats, shoots, leaves. And I thought that was so funny. I nearly fell out of that chair. And they said, "Yep, the drug is working." I knew because I had enough of the partitioning into the CNS that was causing this desired effect. And then I did the procedure, and everything was fine. So again, there are different ways to monitor for the effects of drugs. And sometimes you have to tell a funny story. Maybe one day you'll get to tell that same story to one of your patients. But side effects you're expected to see with this. Hypotension is a very common one. Again, it tends to be a pretty big theme with a lot of these inhaled anesthetics here. Other things you might expect to see potentially is this expansion of the gas in these cavities. Air-filled cavities within the body. You can actually see the expansion, which can be a problem. Not for most patients, but again, think about things like it can cause further distension of the bowel. Right, because again, you have a lot of air in the bowels there. It can cause, if you had things like, tympanic membrane, if it's has a lot of pressure there, it can cause expansion of that gas and potentially cause perforation. Pneumothorax potentially. Again, so there's one thing you want to consider. If there's any cases where the patient is under a lot of gas pressure in any kind of body cavity, this is not a great drug for them in those cases there. And again, this is going to have a high incidence of post-operative nausea, vomiting. You do want to pre-medicate with like Zofran or something like that. Okay. Contraindications include pernicious anemia, immunocompromised patients. This is actually due to the fact that nitrous oxide tends to cause depletion of vitamin B12. So again, patients with B12 deficiency develop pernicious anemia, and it can also lead to myelosuppression. So just be aware of that. You may want to avoid using nitrous for those patients. So here's a handy sort of table to give you an idea of just kind of comparing the different anesthetics together to see what kind of effects you're expected to see here. Again, don't memorize these numbers specifically, but again, get an idea of what the minimum alveolar concentration is between these. And again, nitrous oxide, what do you notice about that MAC for that drug? How's it compare to the rest of these? It's extremely high, right? It's 100-fold higher. What does that mean? We said that the MAC is basically where you get 50% of your patients to not respond to noxious stimuli. So how much of this nitrous oxide would I have to give in order to get to that point? Well, they're not going to breathe any oxygen, so we're going to be dead anyway. So at that point, they're definitely not responding to noxious stimuli, right? So again, there is a limit to how effective things like nitrous oxide can be based off that MAC profile that it has, okay? Versus things like, say halothane, very, very potent agent, did not have to give a whole lot in order to get to that sedative sort of point there. Did you have a question? No, you good? All right. Anyway, you can kind of get a comparison between these. Just know nitrous oxide is an incomplete anesthetic. You're never going to get someone down for general surgery with this, or for kind of maintenance of general anesthesia. But other agents certainly will. And again, the three that I see most commonly are going to be desflurane, Sevo, and isoflurane. Okay. And again, looking at cardiovascular effects, you're expected to see effects on any one of these. And again, mean arterial pressure can be affected by any of these. Typically, it's going to go up or down. Typically down in most cases, right? So for the most part, you're expected to see some drop in blood pressure just due to the natural sort of depressant sort of effects of these medications here. Some cases you're going to see increase in cardiac output, which we know can be problematic in patients who have maybe at risk for MI or CHF or something like that. Looking at systemic vascular resistance tends to be affected here as well. So just kind of be aware of those changes that can occur there, right? What's kind of typical lies in inhaled anesthetics. So other toxicity you can find, we can certainly see some degree of hepato and nephrotoxicity in rare cases here, but we also have this kind of unique sort of thing called malignant hyperthermia. Anyone know what that is? What is it? It's hyperthermia that's malignant. That's true. You could say that. Let's look at what it is specifically. This is actually an autosomal dominant genetic disorder. So this is something that a patient is born with, potentially. And this is why history is so important when you're looking at the providing anesthesia for a patient. The group of drugs that patients are likely to have this with include the inhaled anesthetics, so any of the ones we've talked about so far. And there's a paralytic called succinylcholine. We're going to talk about that in the emergency medicine section later on. Those are the two groups of drugs that can cause malignant hyperthermia. This is potentially fatal and is very rapid when it occurs. And the problem with it is because it's a genetic disorder and we don't have really good screenings for it, it's very difficult to determine who might actually have this, right? So it's very rare. You may never have seen a case in your entire career. totally possible. But when it happens, you want to be aware of it. And this is why when you ever go to like an emergency department or the OR, ask about a malignant hyperthermia cart, because those are the two places you're going to find that. Because those are the two places you're either giving inhaled anesthetics in the OR or you're giving succinylcholine in the ER, right? So we have carts there available just for this particular purpose. But by asking history, hey, has anyone in your family ever had a problem with anesthesia? You can sometimes try to hone in, even if they didn't know it's malignant hyperthermia, you can at least try to hone in and see, like, okay, well, maybe there's a risk, and I can try to delve further to see if this is going to be a problem for that patient. Okay, so history is really key here. So anyway, I'll show you a picture of how this actually happens here, but basically there's a disruption, or there's a mutation in this ryanodine receptor that is responsible for causing calcium to be come out of the sarcoplasmic reticulum. So if you go all the way back to physiology, I know I taught this to you guys, I may have at least covered it once. You know the muscle physiology, when calcium comes into a skeletal muscle cell, what does that cause to occur? How does it cause contraction? You have to go back to actin, the myosin, and all that good stuff. But remember, one of the big things it does is it causes calcium to be released from the sarcoplasmic reticulum. Remember that calcium-induced calcium release? That's an important factor there. So that ryanodine receptor is responsible for that sarcoplasmic reticulum release of calcium. So they have an alteration there where they end up getting way too much calcium spilling out of that sarcoplasmic reticulum. Way too much calcium means way too much contraction. That means you're using way too much energy, which means you're going to be producing heat, and you're going to be producing acid. So the patient gets very, very hot, i.e. the hyperthermia, and they get very acidotic, i.e. they die from this, right? So it's not great. I'll show you a picture to kind of give you an idea what that looks like in just a second here. And it's very difficult to determine. You can maybe do a muscle biopsy if you had someone who had to go to surgery, and maybe you had some time to do this kind of testing here. You do a muscle biopsy to determine if they're at risk. Otherwise, it's kind of, you just have to go off of the history, right? And if they have no high-risk history, you give it to them knowing that there could be a small risk that they have this mutation, and they could be at risk for developing this condition. Okay. So anyway, looking at this, see calcium coming in through the outside of the cell, right? So again, we've had the action potential come along. They open up these calcium channels, and this is the ryanodine receptor that will allow the calcium to spill out. You have way too much that's coming out of here. You're going to have way too much contraction occurring there, so the muscles get very rigid. Anyone remember any other conditions we talked about where they get like really rigid muscles? Well, like more like drug-induced causes. Oh, I see rhabdomyolysis with statins, but they don't really cause muscle contractions like that. It's more like myotoxicity. Dystonic reaction, right? Dystonic reaction leading up to neuroleptic malignant syndrome. You guys remember we talked about that? Which drugs cause that? Your high potency first generation antipsychotics, Haldol, fluphenazine, those are the big causative agents, but really any of the first generation antipsychotics can do that, right? That neuroleptic malignant syndrome is very concerning because it develops similar lead pipe rigidity. You can see rhabdomyolysis with this as well. You can see that heat, that acid formation, all that good stuff, or bad stuff for these patients, right? So they can look very similar to one another, but based off the history, what drugs they've received, you can usually key in on what specifically it is, okay? So, as I mentioned, you're going to have this rapid onset of tachycardia, hypertension. They're going to get severe muscular rigidity, right? And again, these patients were previously pretty relaxed, especially if they're under general anesthesia, and all of a sudden they start to tense up. It's not a good sign. They get hyperthermic, hyperkalemic. Why do you think this happens? Some of it could be due to muscle breakdown, but also think about when you're trying to repolarize these cells, what allows that repolarization to occur? Potassium leaves the cell in order to cause that repolarization of the cells to happen there, right? So again, you're having a lot of potassium coming out of the cell. When you become acidotic, you see potassium also shifting out of the cell, so you get hyperkalemic. Hyperkalemia can lead to ventricular arrhythmias, right? That'd also be another cause for killing these patients here. And then they get very acidotic, okay? So how do you think we treat that? Well, how do you treat acid-base bound? If you have a metabolic acidosis, how do you treat that? And give an alkalizing agent. What's the common one we use? Give them sodium bicarb, absolutely. So we can give them sodium bicarb. And so when you look at these malignant hyperthermia cards, check them out. You may see, you'll see all these agents that are here, and usually there's actually a fridge attached to it as well. So you have sodium bicarb. That's meant there to correct the metabolic acidosis. You're also going to find cooled IV fluids. That's what's usually in the fridge there. Because again, you want to cool these patients down, so you're going to be using evaporative cooling externally, you're going to be using cooled IV fluids internally, try to cool the patients down. And then we also have this drug called dantrolene. A couple of different brand names that are here, but basically what this does is it works as a peripheral muscle relaxant. It helps to reduce this calcium release from the sarcoplasmic reticulum, and again, that's correcting ultimately what the big issue is with these patients. They're releasing too much of that in the first place. And we mentioned this briefly. You can also use this in some cases of neuroleptic malignant syndrome, but not use as commonly as you would for something like malignant hyperthermia here. So anyway, so the big goal is to restore the electrolytes, fix the acid-base disturbance, cool the patient down, and then give them dantrolene, and that will help to relax those muscles there. So again, it's important to recognize this when it occurs because it can be rapidly fatal if not caught and treated early. So, key points here. Inhaled anesthetics are nice because they have good amnestic properties. They have a very fast offset, most of them, especially like sevoflurane and desflurane, and they're going to be good as an adjuvant sort of medication to the IV anesthetics. Again, you're going to induce the patient with IV anesthetics and then start off, then go for maintenance of sedation with the inhaled anesthetics there. Okay, it's a really important part of this balanced anesthesia we mentioned before. Again, monitor for things like malignant hyperthermia. Usually your anesthesiologist or CRNAs will be monitoring for that. And we know what the new sort of practitioner is you might see in place of one of those two. Anesthesia assistant, right? Which I've seen, which I had no idea about just like a year or two ago, but it's starting to become a new thing. Actually, I think Florida Hospital has a program for that. I'm not sure where else, but Florida is one of the places where you might see anesthesia assistants being used in place of the CRNA potentially. But anyway, and then looking for malignant hyperthermia, look out for the post-op nausea and vomiting. Again, most of the time you're going to pre-medicate with Zofran anyway. Okay. Any questions on those? All right. You guys cool if I keep going? Again, if you need to go to the bathroom, just get up and go. You can watch the video later if you want to catch up on any jokes you might have missed, right? Intravenous anesthetics. So let's go over some of these we've already covered before, so I don't need to belabor these necessarily, but we'll talk about them here and their use for surgical purposes here. Now again, intravenous anesthetics, you may find that these are good for induction of general anesthesia, as I mentioned previously. They may be useful as monotherapy, so some of these agents we'll just use for more minor procedures where you just need the one agent to get done whatever we need to do. And then, as I mentioned, also adjuncts to inhaled anesthetics. Very frequently we'll find that you don't get enough analgesia from say something like, sevoflurane or desflurane, and so we'll end up using infusions of some of these other agents via the IV in order to help with the analgesia. So for instance, for some of our cases like with our orthopedic cases, we have like spinal fusions that are going on. Those are particularly painful, and so we'll have patients who are getting inhaled anesthetics in addition to getting a IV opioid infusion. So something like remifentanil. You remember fentanyl and the brothers and sisters of fentanyl? So there's Remi, Al, and Sue, right? So again, brothers and sisters of fentanyl. Remifentanil is a very common one you'll see used in the OR setting there. Anyway, they have a much faster onset. They work within just a few minutes for the most part, and then you get your procedure done, and hopefully we're going to have things that have fast offset so that way they recover pretty quickly there, okay? A lot of them will lack analgesic properties, but I'll mention the ones that do have that because that's important to note. And then again, the recovery time is going to be dependent typically on the dose that they're receiving there. And so I'll give you a good example of this. So for instance, with something like ketamine, we'll talk about this more in detail, but it's a very good agent for pediatric procedural sedation. So we have a kid who comes in with like a femur fracture or something, we can help to sedate them with ketamine, reduce it, and then they're generally good to go pretty quickly. One of the things we're finding is that based on the dose we were receiving, depending on the size of the kid, you could be giving pretty big doses of ketamine. So for instance, our dose, and you don't have to memorize this dose, but our dose we would give is 1 milligram per kilogram IV, okay? So a patient weighed 20 kilograms, we give them how much ketamine? 20 milligrams, right? It's very easy from that standpoint. You know exactly how much you're given. So anyway, one of the things you'll know if you ever go to Nemours for any rotations or anything was we have a contract with Disney. So if anyone gets sick, any kids have any issues at Disney, they come over to us, right? We have a deal with that EMS service. I can't remember who it is that does all that. But anyway, they'll bring them over to us. And so they have the wide world of sports over there. Right? So they have a lot of tournaments and things like that. So we end up getting, especially during the summertime, we have a lot of cheerleading accidents that come in. We have football player accidents and all these different things that are coming in for some of these cases there. Well, some of these football players, they're pretty big guys, right? So again, you have these 16, 17-year-olds that are like, 100, 120 kilos. They're coming in that we need to sedate them for. So based off of what I told you on the dose before, what kind of dose would they be getting of ketamine? 100 plus kilos, 100 plus milligrams of ketamine. So it all seems fine and good. But the question is, well, are we giving too much? Because we saw that the recovery time was actually taking a lot longer. So we checked the research. We actually found that by capping your dose early, you can actually give less drug, get the same effect that you need, and you get faster recovery times. So to give an example, we found that by giving a max of 50 milligrams of ketamine and seeing how they responded, because again, just like with opioids, what did I mention about the dose when you're giving it? You can always give more, right? Can't take it back once you give it. So we'd actually start with a cap of 50, see how they respond. If they need more, we give them more. If not, then we leave them alone, do our thing, and they recover that much faster, and they can get discharged home, right, wherever they're going. So again, just keep in mind these things, that the recovery time is very dependent on the dose you're receiving, and can be dictated sometimes by hospital protocols, or the literature can tell us, some ideas like what doses are appropriate for our patients. Okay. Anyway, so the adjunctive medications we're going to use include our barbiturates, so things like thiopentol. We have our benzodiazepines. So what are some good IV benzodiazepines we've discussed previously? Versed, which is midazolam. That's probably far and away the most common one we use for surgical purposes. What else? Diazepam and lorazepam. Those are the three most common intravenous benzodiazepines you're going to run across. Okay, and you'll see those used pretty commonly there. We have our opioids. So what are some good opioids we use for surgical purposes? Fentanyl is great. Remy, alfentanil are all great. What else? Morphine's a good one. What else? Hydromorphone's a really good one. I think anything else. Those are the most common ones. How about oral options for these patients, maybe in the postoperative setting? Oxycodone's a good one. Hydrocodone, yeah, those are all fine, right? Those are all good options for those patients. So very frequently, patients are coming out of surgery and they're getting, the PAs are writing their post-op orders. We'll oftentimes have 3 different medications set up for them for pain, right? And so we'll say, okay, for a pain scale of 1 to 3, they're going to get, say, oral Tylenol. For a pain scale of, say, 4 to 6, they're going to get oral oxycodone. And then for a pain scale, say 7 to 10, they're going to get IV morphine, right? So by doing that sort of stepwise approach, the ideal thing you want to get is them in the immediate postoperative setting when they're in most pain. You give them the heavy-duty IV stuff, and then you try to wean them off. And eventually, hopefully, they're just using Tylenol by the end of it, because fewer opioids means what? Get them out faster, right? You get them home faster, because again, what do opioids do to the GI tract? Slow everything down, right? Especially if they have abdominal surgery, you don't want them to have post-op ileus. That can be exacerbated by the opioids, right? You want them, to be off of sedating agents that are up and ambulating and moving around and all that good stuff, right? So that's the ideal thing, is to move them off of those IV opioids as quickly as possible, so that way they recover faster and go home faster, right? We'll talk about propofol, etomidate, and then ketamine. Etomidate we'll talk about much more in the emergency medicine section. One's used very frequently for rapid sequence intubation. We'll talk about that there. But then ketamine we use all the time. We'll talk about who the appropriate patients are for that. So barbiturates. I mentioned phenobarb before. That's good as an anti-seizure medication. Not used too often for sedation. But thiopentol, pentobarbital are still sometimes used occasionally. Again, they work by how? What do they do? They help to directly stimulate the GABA A channel to open up and allow chloride to flow in. Remember, these are much more sedating than the benzos on an equivalent dose sort of basis here, because instead of allowing for GABA to work better, like the benzos help to facilitate, these directly stimulate the GABA A channel to open up, right? So they tend to be much more potent, causing hypotension, respiratory depression, etc. But these are good as induction agents. And in fact, this is actually the drug of choice we'd use for patients needing electroconvulsive therapy, right? What do we use that for? Students get wrong answers on their tests, a little shot. No, for as an adjunct to things like cognitive behavioral therapy, really like treatment-resistant depression, things like that, schizophrenia potentially, right? So again, something we would use as a sedating agent to help with that, because again, getting shocked does not feel very good, right? So you try to sedate them a little bit from that standpoint. Again, these lack any sort of analgesic properties, so you'd have to pair this with something that does provide analgesia, something like an opioid like morphine or fentanyl, etc. And you will see decrease in blood pressure, cardiac output, and ICP. What does that stand for? Insane clown posse. You guys are actually wrong on this. No, I'm just kidding. Intracranial pressure. So sometimes we actually use this for patients who may have cerebral edema, or patients who maybe had a head injury or something like that. This is good for if you ever hear like a medically induced coma. These are actually the agents we probably use for that. It helps to really slow things down from a metabolic standpoint with decreased intracranial pressure, and it can be useful in addition to things that help to draw fluid off of the brain, right? So you may see that occasionally. As I mentioned, thiopentol, very good as an anesthetic induction sort of agent there. I don't see it used too frequently from the pediatric standpoint, but in the adults you might see it used a little bit more commonly. But the nice thing here is very useful for patients with cerebral swelling. You may see this more like in surgical intensive care units or like trauma units and things like that. You may see this used a little bit more commonly if they have suspicion the patient's going to have increased intracranial pressure. What's the problem with increased intracranial pressure? Well, it can kill the patient, right? Because again, if they herniate their brainstem, because again, is the skull usually very flexible? Not if they're not a kid, right? So again, that's a very solid sort of thing there. So the brain's only got one place to go. And it's right at the bottom, right? So we don't want that to happen. So by decreasing that pressure, that can be very useful from that standpoint. So I think head injuries, think about using some other common cases, your tumors, things like that can be potentially causes for the increased intracranial pressure. And again, by using multiple medications together, you can help to decrease the total dose that you need. So for instance, by using nitrous oxide along with this, you need total doses that are lower than you would otherwise if you used it by itself there. So things to consider there. Our benzodiazepines, as we mentioned, are very good as a sedative. They're anxiolytic and they're amnestic. Right, so these are all very good things for our patients here. We use this very frequently in the preoperative setting. So most patients, when we're doing our pre-op orders for them, they will end up getting a dose of Versed either orally or intravenously. Because again, most people are probably going to be a little nervous going into surgery, right? They'll have an ER available. If we have kids, especially if they're really needle phobic, we'll give them an intranasal dose of Versed potentially that will chill them out a little bit enough to calm down so we get the IV started. All kinds of uses for these drugs here. And so very good for a pre-medication. Not usually used as itself as an induction agent by itself, usually used with combinations of other things if you're using it for induction purposes. But rarely ever used as monotherapy. But good to kind of set the patient up for other drugs they're going to get once they get to the OR. As I mentioned, the three most common ones for parenteral administration are going to be diazepam, lorazepam, and then midazolam is far and away the most common one used for surgical purposes. It just tends to have the best sort of pharmacokinetic profile because it's a pretty good lipophilicity, gets quick onset, quick offset, and so we like it from that standpoint. Okay, we also use this one intranasally pretty commonly. Okay, which one do you think we use most for seizures? Intravenously. Probably lorazepam. If you're using IV benzodiazepines, lorazepam we like a lot, and then diazepam, you may see them being put on it for like outpatient purposes. Diastat I mentioned, that rectal diazepam, you may see that used more frequently there. Okay, diazepam is better as like kind of a general like muscle relaxant. So you may see some patients when they're coming out from say like an orthopedic procedure, they may be put on PRN diazepam, and they like it from that standpoint because it's a little bit longer half-life, so it sticks around a little bit better. So, as I mentioned, midazolam, benzodiazepine, a choice there. High incidence of amnesia, so again, that's something we like. We like them to not really remember a whole lot of what's going on as they're going into surgery, and because of that, has a good rapid onset, shorter elimination half-life, so it's going to come off fairly quickly as well. Okay. So what happens if you were to give too much opioid to your patient? How could you reverse that? What do we give? You give Narcan, right? So if you're looking at this as like an SAT question, fentanyl is to Narcan as midazolam is to flumazenil, right? So again, this is the benzodiazepine receptor antagonist. Okay. Now, what do you say about Narcan? How much can I give before it becomes a problem? Are there any like big side effects with it? No, I can give as much Narcan as I want. I'm never going to see a problem with it. This is not the case with flumazenil. You have to be really careful with this one, especially for patients who are chronically taking benzodiazepines. Because just like, what's the big concern with giving too much Narcan to a patient who's on chronically on opioids? Withdrawal. If I give a patient who's chronically on benzodiazepines, flumazenil, what can I induce? Withdrawal, which can ultimately end up in seizures, right? So you have to be really careful with that. Now, for instance, if I have a little kid that got into mom's, Xanax or something like that, he came in pretty sedate, he's never been on it before, I can give as much flumazenil as I want, no problems, right? Just like Narcan would be fine for that kind of patient. For older patients, if I was treating a mom who had overdosed on her Xanax, you have to be very careful, and actually we probably wouldn't even use this. Because for the most part, your patients, do you need them awake? If you think about like an overdose patient, do you really want them to be awake? No, you just want them to be breathing, right? So often we don't really even need this from that standpoint. But it's good if we give too much of a benzodiazepine, say iatrogenically, if we gave them too much, we can reverse them with flumazenil pretty easy, very decent drug from that standpoint. Okay. And just keep in mind it has a short duration of action, so they may need multiple doses they've received, especially big doses of benzos. Okay. But again, this only works for benzodiazepine. It does not work for barbiturates, does not work for the inhalation anesthetics, does not work for anything else, just benzos. Okay. Yes.
Just say if someone like drink alcohol a lot, like drink a lot of alcohol and benzos, would it be as effective, or?
It would be partially effective, right? Yeah, because it wouldn't mitigate the alcohol effects, wouldn't really mitigate the benzo effects. So they'd still be sedate from the alcohol, but not necessarily from the benzodiazepines anymore. Yep, for sure. But that's a good question because that's a common co-ingestion. If you look at a lot of overdoses, alcohol is generally the common denominator between a lot of them. People are depressed, or they're trying to harm themselves, or they're abusing it for You know, maybe they want to go out for a night and have, you know, a cheap night and say, oh, take a Xanax along with my alcohol. I need less alcohol. And their inhibitions are down. They say, let's keep drinking. And then they run into that. Yeah, so it's a common co-ingestion with a lot of those things. Anyway, so opioid analgesics, we talked about a lot of the common ones we're into, you know, fentanyl, morphine, hydromorphone, what other ones we talk about? It's probably the big ones you're going to see used from an IV sort of standpoint, but certainly in the postoperative setting, oxycodone, hydrocodone are all totally fine as well. Nice thing about this is that you don't want to use these by themselves necessarily for anesthesia because you can still have some awareness that's there. So frequently, if they're used for sedation, we're going to apply these along with a benzodiazepine to get a little bit better sort of amnestic quality. So for instance, if we have someone who's in the ICU who's intubated, now again, if you imagine if you were totally aware and awake and you got intubated, would you be very compliant with that ventilator? Big tube down your no, right? So you have to sedate the patient in order to make sure they're going to be compliant with that. They're going to be cooperative. And so very frequently you'll see them being on a combination of 2 drips. It'll be on a Versed drip or midazolam plus fentanyl. Those are the 2 common drugs you'll put together to help someone be synchronous with the ventilator because they'll be sedate, they'll be have analgesia. That works pretty well there. So again, not used by themselves very typically from a sedation or anesthesia sort of standpoint. Other big things to consider, as well as that really big doses of fentanyl, given all at once, can cause chest wall rigidity. Why could that be a problem? They can't ventilate appropriately. All right, exactly. So how do you think I'd fix that? Yeah, you can either give a paralytic or potentially give Narcan. That would actually help to reverse that as well. So that's something to consider. But it's usually a very rapid administration of big doses of fentanyl is going to cause a chest wall rigidity. So that's something to consider there. But again, the big things we want to focus on is getting as little opioids, especially in the postoperative period, as possible, because we know that's going to lead to a lot of side effects. You know, you have to worry about things like prolonged ventilatory support. You worry about GI and bladder complications, etc. So again, the ideal thing is to try to get them off of these. But when you need them for the analgesia, they're very useful from that standpoint. Okay. Again, a lot of times we'll try to use these from an epidural sort of standpoint because again, it's nice, especially if we only need local sort of effects there. So, for instance, if we have someone who is going to labor, about to have a baby, we don't need the entire body to have all the analgesia, right? The top half of the body is usually pretty okay to go, but it's that bottom half we want to try to anesthetize a little bit, provide the analgesia, and so that can be useful from an epidural standpoint. They just need certain areas being affected. Yep. Okay, as mentioned, fentanyl and sufentanil, these are super potent agents. So what are the doses usually in? What are the units? Micrograms, right? So be very cognizant of that when you're dealing with these drugs and the relative potencies between them, okay? So for instance, a typical dose of IV fentanyl for a patient, just for typical analgesia, may be 50 to 100 micrograms, which is very different than, say, for instance, hydromorphone, maybe you're doing a quarter to half milligram, versus morphine, I might be giving, say, 2 to 4 milligrams. Keep those potencies in mind, because again, if I accidentally put in, say, 50 milligrams of fentanyl, well, that's enough to probably kill this whole room, right? If I accidentally put in something like 0.25 micrograms of fentanyl, that's not going to be enough to actually treat the patient, right? So again, you have to be aware of these kind of different relative potencies, and if you work in surgery or work with any patients, you'll get a feel for that over time, which is why I don't really have you memorize all the doses, but you'll get a feel for it, right? That's part of what ClinPharm is for in the summer, is to start to get you familiar with those doses there. Okay. As I mentioned, Remy and alfentanil we use pretty often as adjuvant agents during surgery to help keep them sedate. So we use this a lot for our cardiac patients, like open heart surgery patients, our spinal fusions, things that are very invasive, very painful procedures. This is where we use a lot of IV opioids during the procedure in order to help keep them that analgesia there. Other morphine we mentioned, alfentanil, all the fentanyl congeners are all going to be fine there. When I say congener, what does that mean? What that term means? Basically, it's something that's kind of like a cousin to it, right? So I mentioned fentanyl, alfentanil, sufentanil, remifentanil. Those are all congeners of one another. They're just all kind of in the similar sort of category, and so you may see them used somewhat interchangeably depending on the situation. So just kind of keep that in mind. If you ever hear that term, that's what that's referring to. Okay, so keep in mind all the things you want to know about opioids, right? So know the common complications of opioid therapy. You know it's going to slow down the GI tract. Know it's going to, which one's most likely to cause a lot of, flushing and itching. Why morphine? It causes a lot of histamine release. Is that true allergy? No, right? What else do opioids commonly cause that may happen after surgery as well? Well, constipation, but maybe like immediately post-operatively. Nausea, vomiting, right? You want to think about that as well, right? So think about things like Zofran being needed to help try to prevent that. And so very frequently when I look at our post-anesthesia orders that our anesthesiologists are putting in for patients, they usually have a dose of an opioid. They usually have, say for instance, a common combination I'm going to see is like fentanyl. They'll do, 3 doses, Q5 minutes, PRN pain. So for breakthrough pain, so they're coming out of surgery, they're waking up, they're in a lot of pain, we'll give them fentanyl. They'll have an order for Zofran to use as needed for nausea, vomiting, and then that's usually the most common combination. They may get some fluids additionally if they need a little bit of perking up from that standpoint, but that's common things you're going to see in the PACU sort of setting. Up next we have propofol. Some people call this the milk of amnesia. Anyone know why? Never seen it? Google a picture. It looks like milk basically. It looks like a little bottle of milk there. It's very white. That's the lipid base that we have to put the drug into to keep it soluble essentially, right? And so it's a very good agent from a sedation standpoint, relatively short acting. We can either use it for induction or for maintenance of anesthesia. So as I mentioned, for patients who are intubated, we need to give them sedation. We can either give them like a Versed fentanyl combination. Sometimes patients would respond just to propofol by itself, which is nice from that standpoint. We also use this very frequently for outpatient or ambulatory surgery when we are dealing with adult patients. Propofol is very nice from that standpoint. We'll talk about one that you do not want to use in adults too frequently, why that is in just a second. But propofol is great from that standpoint. So it's also working as a GABA-A receptor agonist. It's directly stimulating GABA to hyperpolarize those cells. As I mentioned, good for IV anal sedation in the operating room, procedural sedation. We use this a lot in adult ERs and things like that. If we need prolonged sedation in the ICU. Okay, so just be aware that you may see patients who are intubated who are using this for sedation chronically, right? So if you're ever like looking at a patient, you're looking at all their IV lines, you see one that's just pure white, that's usually going to be the propofol that's infusing in them, right? Or it could be like lipids from a TPN, but usually it's propofol if they're in the ICU. Now, because it's in that lipid base, you have to think about that when you're thinking about things like nutrition, right? So that all that lipid there counts as fats that they're receiving. And remember how many calories you get per gram of fat besides Ashley? I don't mean to single you out, but I just know you know off the top of your head. How many? 9, yeah, absolutely, right. So like proteins, carbohydrates, I think 4 generally, and then 9 for fats. So in some cases, you have to think about that, what that's contributing. If they're getting really high doses, that could be a factor, especially in small kids. And then other thing you have to think about is it can cause hypertriglyceridemia. So this may be a reason to discontinue the medication potentially. And then there's also what we call this PRIS syndrome that occurs here. It's a propofol-related infusion syndrome that happens if you have really high doses for a long period of time. You can actually induce this acidosis that occurs there, right? So sometimes you might be asking, well, is the patient getting sicker? Is it the sepsis causing the acidosis? Or is it the fact that they have this propofol is running really high rate for a while now? Other big things you see here is this will cause hypotension. And again, it's dose related. So if you have them on a really high dose needed to keep them sedated for that ventilator, you're going to see that hypotension go along with that, which can be a problem if you have someone admitted to the ICU for sepsis, because what's a common thing you find with sepsis from a cardiovascular standpoint? Hypotension, right? So I remember one time I was on rounds in the ICU when I was on in my fellowship, and we were walking around the medical team with these patients. They're on 3 different pressors. They're on dopamine, they're on epinephrine, and they were on norepinephrine. All 3 of those together because they could not keep this patient's blood pressure under control. They're coming in for sepsis, right? So all these antibiotics, all these pressors there, and I was looking at sedation, what they're on, and sure enough, they're on propofol. And I was like, well, propofol causes hypotension, right? And they're like, oh, really? And so sure enough, they took off the propofol, and all of a sudden the patient came off 2 of the pressors. They only needed the dopamine at that point in order to maintain good cardiovascular support. Now, I don't mention that to try to puff myself up at all, but it's a good catch, right? It's something you want to consider there. Like, what are the interactions between these? Because sometimes you're treating a side effect and don't even realize it for these cases here, right? So just remember this causes hypotension. You can definitely see that, especially for procedural cases where you're giving a big dose, just kind of intermittently, just kind of one at a time. You may see some drop in blood pressure, which could be fine for a lot of patients, maybe problematic if they're already hypotensive to begin with. Now, as I mentioned, very rapid acting, has a very short duration of action, which is great, especially when you're running as a continuous infusion, because you can titrate it pretty easily to the level of sedation that you need for those patients. One thing to note, though, and I always mention if something changes the color of your urine or your feces, this can actually turn your urine green here. Interesting, though. I don't know why it causes it to turn green, but if you ever see that, normally you think, ooh, that looks infected. That does not look good, right? But it could just be the propofol that we're receiving there. Okay. So we'll hit the respiratory drive. So again, really everything we looked at so far can cause hits to the respiratory drive. Probably benzos are the safest from that standpoint so far, but barbiturates, opioids, Propofol are always going to cause a decrease in respiratory drive, and we know that. And again, you need to monitor from a respiratory standpoint. And again, it could be the rate of breathing, it could also be the depth of breathing. So what are some things we can look at in order to determine if a patient is becoming hypoxic? Okay, you can look for cyanosis. Usually for that point, things are, yeah, how can you find it before then? You can do an ABG, it's pretty invasive though. O2 sat, right? So you know O2 sat. However, what do we say patients normally kind of lose the response to before they actually drop before they become hypoxic? What's the other component of that? Typically the brain's more sensitive to CO2, right? So this is where in-tidal CO2 levels can be very, very useful there. And you're starting to see more monitors that can monitor this. Call that capnography. And so by looking at that, you can actually determine if the patient starts to hold on to CO2 far before they become actually hypoxic. So that's something you want to look for if you can to determine that, right? Usually 35 to 45 is typically a decent CO2. PCO2, once that starts to rise above that, they're holding on to that carbon dioxide. They probably need to come off the propofol a little bit. Okay, makes sense? Because again, that O2, that can be sometimes, it's kind of like 4 minutes behind where that patient's actually at, because again, we're measuring it peripherally, and again, that blood's been circulating for a while. It takes a while for that to really catch up. Okay, so something to think about. And again, you said who made it famous? Michael Jackson, right? So he famously died from a propofol overdose, and again, that makes sense based off the respiratory depression, the apnea he probably experienced with that. Again, a little funny side story. So we, as part of my fellowship, we would take our rotators to the Jacksonville Zoo every month. They were there, and because we had a relationship with the herpetologist, strictly platonic, it was just professional. But we had a relationship with them where if we had like really, exotic snake bites that were coming in, we get anti-venom from them and administer that. And anyway, so we would go and do like a behind-the-scenes tour there. Little known fact though is we actually had an elephant at the Jacksonville Zoo that was donated from Michael Jackson's Wonderland Ranch. Right, so I say, can you tell which one's the Michael Jackson elephant? They're like, oh, how can you tell? I was like, it's one walking backwards. I was telling them it was a little hard to break him with the propofol, but we got him off of it eventually. Right? It's been a long enough time I can make that joke now. So anyway, we have a morbid sense of humor in toxicology. But next up, we have etomidate. This is another very good sedative agent. You see much more used in the emergency room setting, particularly for induction of sedation prior to being intubated. Typically, when you're intubating a patient, you need 2 drugs in particular. You need a sedative agent, and then you need a paralytic agent to kind of loosen up all those muscles there in the airway, so that way you can intubate the patient kind of without complication. This is that induction agent we use probably 8 times out of 10, I'd say, for most patients there. The nice thing with this one, it caused relatively minimal effects on the cardiovascular system, so it doesn't really hit the blood pressure, doesn't really hit heart rate, doesn't really hit the respiratory drive as much as some of these other agents like a fentanyl or a propofol would. So from that standpoint, it's very good to sedate the patient, do what you need to do, and then get out. You'll sometimes see this used as well for things like shoulder reductions, if a patient dislocates a shoulder, things like that for adult patients potentially. One thing you do want to know is that, actually I don't have it on the slide here, but again, usually it's going to be administered with opioid analgesics, because again, these don't provide any analgesia. So if you're doing something painful, you want to provide some additional analgesia with an opioid. And again, the recovery is really nice here. Less than 10 minutes, patients should be kind of waking up on their own. So one thing I want to note here is this adrenocortical suppression. This is really important because what you can actually find is you can cause a transient adrenal suppression for these patients, which can be problematic. And if you think about it, if you're suppressing cortisol production in the adrenal glands, what could be a side effect of that? See, from say a cardiovascular standpoint. Well, if you remember, there's the glucocorticoid effects of hormones or steroids, and then there's the mineralocorticoid effects. The mineralocorticoid effects does what? Keeps your blood pressure up, right, by holding on to fluid there. If I were to cause, and I had a patient, say, come in who was septic, you already know they're going to get hypotensive anyway, and we give them etomidate, that's something you want to let the ICU team know because of the fact that you can cause this adrenal suppression. They may need to give them additional hydrocortisone to try to get that additional mineralocorticoid effect back to get that blood pressure stable. So that is definitely something you want to be aware of. And then if you're admitting the patient, you want to look back in the records to see what they got, because that could be playing a role there with their hemodynamic stability. So you see some nausea, vomiting here. You can see some myoclonic activity potentially. So you can see some jerks and the muscle there. Sometimes that can actually lead to trismus, which can be problematic if you're trying to intubate the patient. You usually want their jaw to be nice and loose. However, if you give them a paralytic, that's usually going to loosen up anyway, so that's not too big a problem. And then we have one of my favorites, ketamine, Special K. It's a lovely drug. I love to give little kids ketamine, professionally speaking. It's a very nice drug from that standpoint. This is cool because it has a kind of a novel mechanism. It doesn't really work on GABA specifically, but instead of helping to facilitate GABA working better, this actually helps to inhibit the opposite of GABA, which is glutamate. This is actually an NMDA receptor antagonist, and so you'll find this kind of falls into similar categories with a lot of kind of psychedelic sort of medications there. But blocking NMDA receptors, and actually this is chemically related to PCP. Anyone familiar with that drug? That's good. It's kind of like a 70s, 80s kind of stimulant there, but it stands for phencyclidine. Another common name for it is angel's dust. I've probably never seen PCP clinically ever present here, but it actually does something very similar there, which is important because we'll talk about some of the effects you're going to see with that in just a second. The nice thing about this is it provides what we call a dissociative anesthetic state. You know what that means when I say dissociative? Kind of like a mind out of body sort of state there. So even though the body is still experiencing pain, that connection between the body and the rest of the CNS isn't really making a connection there. So what you find is these patients are sedate. They're not really responding to painful stimuli. However, they may not be fully unconscious, as the case may be, right? Because again, they still may be experiencing some things. We'll have patients who will still talk potentially during sedation, even though we're performing very painful procedures and they're not feeling any of it. I kind of talk about patients going on a trip. And again, they talk about tripping on something, like this is basically what they're talking about. It's a dissociative sort of effect there. Yes, sir.
Is that what they would use for those neurosurgeries where they let them play instruments and stuff?
I'm not familiar with those surgeries. I don't know. I have no idea.
Just thinking
I don't work with neurosurgery too often, so I don't know. What kind of instruments are they playing?
Well, they used to do it for like musicians
Okay.
to see, if they were pushing on the right part of the brain to not affect the them.
I don't know. That's a good question. You can probably do some research, and if you see ketamine on there, then you'll know, right? So the nice thing about this is that because it's not really affecting GABA so much, it has really no hit on the respiratory drive, so which is good because again, if I'm doing a short procedural sedation, say in the ER, I don't have to worry about intubating that patient. That's kind of a side effect I don't want to think about. And so we'll still monitor these patients. We'll still have an RT at the head of the bed to monitor for that, but it's usually something we don't have to worry about so much with typical standard doses that we're giving. So that's one thing we like about it. The other thing you're going to find is that ketamine will stimulate release of catecholamines like norepinephrine, epinephrine, which can lead to what sort of effects do you think? Vasoconstriction, I see tachycardia, hypertension, right? Be stimulating the cardiovascular system, which is good. What do you think that extra stimulation, say, on the bronchial smooth muscle might be? Bronchodilation. Who might that be good for? Yep. So if you have someone who has status as manicus, and you need to intubate that patient, ketamine is actually a really good drug for them because it has some additional bronchodilation sort of effects that none of these other agents actually have there. So this is where you're starting to think about, okay, well, this type of patient, this is the kind of drug I want to use versus this type of patient, this is the kind of drug I want to use. You'll get a feel for that as you get more comfortable with them. So it's nice because it will, they're very unresponsive to outside stimuli. They have good amnesia, good analgesia, and again, they may not have full loss of consciousness. So we'll tell, because over in the peds ER, we'd let the family stay in the room. Sometimes the parents feel a little bit better if they can actually see what's happening. We tell them, listen, like they may be responding, maybe talking, but they're not there. Like little Johnny is off somewhere else. And we frequently tell them, it's like, listen, like, we were talking to the patients, like, what do you like to do? What's your favorite thing to do? And again, a lot of times they're here, like they're visiting because they want to go to Disneyland. So it's like, who's your favorite Disney character? I'm like, oh, Mickey Mouse or whoever. And we'll say, all right, think about Mickey Mouse. Think about having like a really good time with Mickey Mouse. And then sure enough, that's specifically what they dream of. The very vivid dreams, like, oh, how was your time with Mickey? And like, it was awesome. We went and rode Splash Mountain and all this other stuff. And, so they have a decent time with it. Now, there's some patients who have a very bad time with ketamine. We call that tripping down the K-hole. This is not good, right? So typically, we do not like to give this to adult patients. This is a very kind of peds focused sort of drug here. Now, there may be some occasions where I use it for adult patients, but typically adults have a little bit more psychological baggage than some of these kids do. And so people can have a very bad trip. They get like really nasty hallucinations. They can get very anxious. They can get very aggressive sometimes when they're coming out of it. All right, so they have this dysphoria that occurs there. It makes it not really an ideal drug for a lot of those patients. That's where we like to use a lot more propofol for more adult patients. We like to use a lot more ketamine for kids. Kids just have a little bit more nice, pure Snow White kind of mind, and they do much better with it, right? So just something to kind of keep in mind. That's why we like ketamine so much for the patients. And also, it does not hit the respiratory drive, which is great because we don't have to worry about them going apneic. Again, this is really on the IV. The only IV anesthetic we've talked about that has both anesthetic and analgesic properties, which is why we like it so much as well from that standpoint. There's some concern that you may increase ICP with this drug, although I don't know if there's any evidence to really back this up. But if you have a patient who maybe had a head injury, this is definitely one that most of your neurosurgeons would want to avoid, just to mitigate any risk of that, right? Propofol would be better from that standpoint to try to lower that, if anything. And then I mentioned the high incidence of post-op psychic phenomena. That's a dysphoric reaction. How do you think we treat that? Yeah, benzos basically, right? So we need to give them some Ativan or some Versed or something to try to chill them out. There's also a lot of nausea, vomiting associated with this, so we will go ahead and give them some Zofran as well to try to mitigate any of that. Because again, they still might not be protecting their airway appropriately. Just depends on the patient there. Okay. So again, as I mentioned, sedative of choice in status asthmaticus due to that bronchodilatory sort of effect that it has. Okay. Again, here's a good table to go back through and kind of look at. And again, think about which are the only ones we've talked about that have reversal agents. Benzos, just flumazenil, and then opioids. That's it. All the rest of these, they don't have reversal agents. So if you accidentally gave too much, what do you got to do? You got to wait it out, right? You got to wait for the drugs to go out. And again, most of them are going to have short durations of action anyway, which is fine. But just be aware of that. You have to treat them supportively through that. Again, if someone has a dysphoric reaction from ketamine, you know how to treat that. Give them benzos to try to calm them down. That's usually the best way to manage that. Okay. All right, so I'm going to go ahead and cut it there. Let me check the board to see if there's any questions before I cut this off.